I've already apologized to the camera woman because I do move a lot as I talk, and because we're spread out long in here, I will probably do even a little bit more pacing than normal, but I'll try not to make anyone dizzy, including the people who are watching on video. I've watched those videos, especially comedians. Have you noticed? They're like caged tigers, and they're just constantly moving back and forth. I'm like, slow down. Slow down. You can still give me good comedy without making me dizzy. So I'm going to do my best today to include all of you, to watch for questions, to watch for raised hands without making you dizzy or the people on the camera dizzy. I would love to start by just getting to know you guys a little bit. So I feel like it's worth our time to just take a few minutes and go around the room. I'd love for you to share your name, kind of what branch you're in here in Methodist, kind of where you fit in the system or wherever you are if you're not part of the Methodist system, and something that you are hoping you might gain from today. If it's only CEU hours, it's okay, I won't judge, okay? So let's just start over here. We'll kind of snake around the room. Thank you guys for letting me take that time. It may seem like a waste of time for you, but my hope is as we go through the rest of the workshop, the information I've just gathered is going to be helpful in helping me kind of know where to sit from time to time. When I first talked to Ashley, because PTSD is just what I do. You don't start your career with survivors of human trafficking and not get your, up to your eyeballs in trauma and PTSD. And something we'll talk about here called complex PTSD, which I think is important for you to know about. So all of this information is going to ramp us up. But when I talked to Ashley about this course and began talking about postpartum PTSD and what that might look like, it began to click for me that someone I was very close to in my past, in one of the states that I've lived in, probably had a post-traumatic birth experience. And this individual is case study number 2. When I put on Facebook that I was going, because you want to let people know, hey, if anybody's interested, I'm doing this class at Methodist. Another friend that I had known at some point in my life emailed me and said, I think that I experienced this. So I began to talk to her. She's case study number 1. So I just wanted to let you know that these case studies are not a compilation of different people that I put together. Much of them is their words. They wrote their story. I went in, edited some stuff out, switched some stuff around, but it's very much in their language and their experience. So when we get to that point, I want you to know that these are real people's stories and not just a character that I made up. So we're going to start with PTSD. We're going to talk about different levels of PTSD, and then we'll move into the specifics of how it impacts trauma. I am a talker, and it will not throw me off if you ask questions. So at any point, if you have something that you want to share or you have a question that you want to ask, flag me down or just shout something out. It is not going to bother me. I'm not going to get off my rhythm and get all flustered. Please feel free to ask questions. I will try and remember to stop and let you ask questions. But if I don't, interrupt me, please, because that's where you're going to get your largest value, okay? Some of you mentioned that you have had experiences specifically related to birth trauma. Some of you may have had experience related to other types of trauma. And I just want to give you permission, if things start to feel a little bit heavy, go get a drink of water, go to the bathroom, take a little walk. Everybody here has been drinking coffee and water this morning. No one is going to know why you left the room, okay? Everybody is going to leave at some point. So please don't feel hesitant. Please don't feel like anyone's watching or judging. Take time to take care of you if you need to. Come see me during the breaks. If you feel like you're having some interesting symptoms that you need a little bit of help with, I will be happy to help navigate that with you. But hopefully that won't happen. But just my kind of common disclaimer. All right, we ready to get started? Yeah. All right, so diagnoses that can come as postpartum. Okay, that can come postpartum. Who here has heard of postpartum psychosis? Anybody? Okay, a fair amount of you. The NICU, I noticed there's a lot of NICU. Postpartum depression. How many people in here have heard of postpartum depression? Probably almost everybody, right? What about bipolar 2 coming postpartum? Yeah? Do you guys know the difference between bipolar 1 and bipolar 2? So bipolar 1 is your more traditional manic symptoms when you think of mania. Bipolar 2 manifests a little differently. It tends to manifest with anger or irritability, which can make it a little bit harder to diagnose. Sometimes people will just kind of, oh, they're just grouchy or whatever. But because you've got all these hormones that are changing in your body, right, around the birth process, bipolar 2 can happen postpartum. Postpartum anxiety, you guys familiar with postpartum anxiety? I imagine that one's actually probably just as common as postpartum depression and maybe not as often diagnosed. Under postpartum anxiety, though, we have postpartum obsessive compulsive disorder. Anybody heard of that one? 2 of you? Okay. I actually hadn't thought about that. I don't know why I hadn't thought about it. Because you think, well, mothers are protective anyway, so how do you know the difference? There are definitely some differences, but that's a different class. Panic disorder postpartum. Anybody heard of that one? No? Okay. And then PTSD due to childbirth, and that's the one we're going to sit on today. So you can imagine with all of these possible things that are going on, you know, there's a lot of things you could do. There's a lot of things you could look for. It is going to be impossible for any one person to be completely aware of all the different things that can happen postpartum. So the more that we can educate across different, you know, types of helping positions before, middle, after, the more likely someone's going to recognize something. So today, my hope is to give you enough tools that you will be people who are good at recognizing postpartum PTSD, or at least those who are at high risk for it. Okay? So there are 3 different things that we could talk about: post-traumatic stress disorder, and complex stress disorder. These are 3 different levels of diagnosis. Post-traumatic stress, most all of us in this room are old enough that we have actually experienced post-traumatic stress at some point. Generally, through resiliency factors, through community, through people who help us walk through it, we are able to walk through those symptoms within 30 to 90 days. You know, 1 to 3 months, and we're kind of back to relatively normal. We're not having major symptoms, but often we have symptoms for a couple weeks after something happens. Very common. This is what we call subclinical, post-traumatic stress, subclinical. The reason it's important to be aware that it happens is because trauma is cumulative. Traumas build on one another, okay? So something that may not seem super traumatic, if it's coming in for someone who's had a million mini traumas, that could be the one trauma that sends them over the edge, okay? So post-traumatic stress is subclinical. PTSD we're familiar with. We're going to talk about that a little bit more. Complex stress disorder, CTSD. This is generally cases of survivors of child abuse, survivors of domestic violence, survivors of trafficking. These are people who, well, we'll go over some of the difference, but it's really important that you have a glimpse of that as well, because if you have a mother that is a CTSD survivor, there is a much, much higher chance that she is going to feel like this is a traumatic birth experience. And she may be a harder client to deal with, which isn't that fun. The ones that probably need our help most are the ones who are constantly pushing us away and cussing at us and telling us where to go. That's always fun. So only 20% of those who experience trauma develop PTSD, or 20% of those who have PTS, post-traumatic stress, go on to do complex PTSD, right? So 2 out of 10 who experience trauma are going to accelerate into the highest trauma diagnosis. If you look at I did the math, and I'm not going to try and do it in my head now because it's too hard, but it's pretty comparable when you look at postpartum PTSD symptoms, which would be comparable to post-traumatic stress, is 25 to 30% of moms. So we're talking at least 1 out of 4 moms experiences some kind of traumatic stress during their birth. However, only 1.5 to 6, depending on your population, go on to actually full-blown postpartum PTSD, right? So again, we're looking at those resiliency factors, the people who do not move on, because there's a huge percent of those. You know, you take that 1 out of 4 and you put them all in a room, there's only a very small percentage of those that are going to go into full-blown PTSD. Why is that? Well, they probably have social support. They probably have healthy attachment from the past, some healthy attachments in the present. They have a place to find and process those things, right? So those are some of the successful things. But it was interesting to me, that the statistics very closely mirror one another when you kind of look at them. So I think that's all the math for today. Okay. All right, PTSD. We have the pillars of PTSD. I should have asked if anyone knew what they were before I put them on the slide. So who can tell me what is hypervigilance? Get you guys talking a little bit. What's hypervigilance? I was a teacher before I was a counselor, so I can wait forever. Does no one actually know what hypervigilance is? Yes.
Well, what we see in the NICU is that's always there, always on the edge of her seat, always questioning everybody, the same question over and over and over.
Mm-hmm. Yep. So hypervigilance, I want to have my back to the wall. I want to be able to see the entrances. I have a sentry that's always looking. I'm always alert. These people often have some trouble getting to sleep. Not always, but often, right? It is vigilant. They have their little mental sentries are always on guard. Little periscope always on guard. Avoidance. What might avoidance look like? In general, it doesn't have to be in labor and delivery.
People that never come around, never come to visit their babies or
Yes.
stay away.
Yeah. Especially, you think about the NICU or other times when the baby's hospitalized but the mom's already gone home and you notice the mom is not coming back to the hospital to visit the baby. That's a great example of avoidance in postpartum PTSD. Very good. Re-experiencing, what might that look like? Say that again. Flashbacks. Mm-hmm. Flashbacks, nightmares. There's something called somatic flashbacks. Have any of you heard of somatic flashbacks? This happens a fair amount at airports. Of course, a lot of my clients are clients that have survived sexual trauma. And what happens if you don't stand the right way in that little x-ray machine? They bring a wand and jack it clear up into your wahoo and whatever, And they won't necessarily have memory flashbacks, but they'll start shaking. Some of them will start crying. Can I just tell you as a pet peeve of mine that TSA is not trained in trauma-informed touch? Because either you're stuck in a box with someone, which doesn't feel safe, or you're being violated and physically re-experiencing this in front of everyone. So that's an example of somatic re-experiencing. And somatic re-experiencing, we're going to talk about, happens a fair amount in giving birth. Think about sexual abuse and the things that happen, and think about the sensations of giving birth, right? There's a fair amount of re-experiencing from post-trauma, or from previous trauma, that can happen while giving birth. And then negative cognitions. Cognitions are thoughts, right? So thinking negatively about something. When I think about this, I have very negative thoughts about it. Honestly, the reason that those are yellow and this one's white, I don't even test for that one. If they've got the other three, I count it as PTSD and just assume the negative cognitions are there. Because if the other things are happening, of course, they're thinking negatively about it. So that's just me. Any questions on just PTSD in general? Just the diagnosis in general? We're good? All right. Have to find a way to get you guys more chatty. So I talked about PTSD and complex PTSD, some of the different research. So your research on PTSD is generally war-related trauma. For complex trauma, we're looking at literature on child sexual abuse. Those are the primary differences when you're looking at historical research in these areas, okay? PTSD, isolated traumatic events. This is single incident trauma. Maybe there's been 2 or 3 single incident traumas, but EMDR works really well for this. Processing, exposure therapy, those are great for single incident PTSD. Complex PTSD, we're looking at chronic trauma or multiple traumatic events. So either the trauma happened repeatedly, the same type of perpetration, or the same perpetrator, or they had many traumas that were similar. We're looking at complex PTSD. Regular single incident PTSD, the trauma source is usually not someone that they're in relationship with, right? War trauma is generally not, you're not injured by someone that you know or someone that's supposed to be taking care of you. Complex trauma, 9 times out of 10, either the source is someone, a parent, an uncle, a caregiver of some kind that was supposed to be taking care of you, that you had been taught that you were supposed to trust, or you have been groomed into a relationship, right? So are you guys familiar with grooming? Who can tell me something about grooming? What do we know about grooming?
Well, it might be like a coach.
Mm-hmm.
That's established a trusting relationship. Like, you're my favorite, you're my best
Yes.
player. You know, come and have a sleepover with me, and then they violate that trust. And,
Yes.
you know, incorporate it to the relationship.
That is an excellent example of grooming. Yes. Right? There's this drawing in. Trust me, right? They're very purposefully creating a trusting relationship. So when the trauma happens, the trauma is coming from a trusted source, someone that you had been wooed into and began to trust. That's part of why domestic violence, partly because domestic violence tends to be cyclical, so there's multiple traumas, but a big reason why domestic violence survivors may present with PTSD, complex PTSD, is because of the intimate relationship. It was a person that was supposed to be protecting them, their life partner, that actually was the one to tear them down and sometimes physically abuse them. But honestly, because of that intimate relationship, in this category, verbal abuse can cause a lot of the same problems that someone who maybe has been through physical or sexual abuse. So again, PTSD, war-related trauma, natural disasters, single incident rape, physical injury, whereas complex PTSD, we're looking at child abuse and neglect, domestic violence. PTSD, if you've got a good therapist and you have good attachment styles from childhood, which really is a big thing as well, poor attachment in childhood, more likely to have severe trauma, long-lasting trauma symptoms. But if your attachment from childhood is good, you've got a good social support system and a good therapist, PTSD therapy can be relatively short-term. Maybe a year or two, but relatively short-term. Complex PTSD, we can be talking 10 to 15 years of therapeutic work because we're changing how we interact with the world, we're changing lenses, we're trying to figure out boundaries, what does that look like? There's this upside down thing that happens in complex trauma where I'm constantly, because of my hypervigilance, I'm constantly reading body language. I'm constantly reading it. I can walk into a room and tell you who's dangerous, except when it comes to the people I trust the most. And when that happens, I fall into these patterns that repeat my trauma over and over and over again, right? Okay, any questions on PTSD versus complex PTSD? Any thoughts as to why I took the time to differentiate? What do you think? You're all like, I don't know, lady.
So we can kind of help sort each one out.
Mm-hmm. Yeah. A little bit of a division because your complex PTSD clients, again, or patients, these are the ones that are going to be your highest risk of experiencing birth trauma or of having negative experience, okay? Because complex trauma affects your ability to communicate well with others, it affects your ability to trust, and because there's a higher potential that there's been sexual or physical trauma that may be dissociated, because that's another marker of complex PTSD is dissociation, okay? All right. Any other questions, comments? No? We're flying. All right. Pre-existing. So what are you guys looking for? So there's a couple of screeners that Ashley put together for me I put them together, but she got them all in a nice little thing and with your packets. So these are, what do you call it? Free domain, whatever. Anyway, you can use these, you can copy them. They're not restricted by license. And you'll notice on the references that these are peer-reviewed, whatever scales, right? So these are scales that have been tested. There's been research on them. You don't necessarily have to use them. You're certainly welcome to incorporate these scales into what you do. But I gave them to you just to kind of get familiar with, because sometimes just knowing these things helps us drop something into conversation, right? Birth expectations. I can just drop some of these things into conversation. And I might decide to do a screener and actually know, hey, as part of this class, I want you guys to look at this screener. Or you could bring in your own little examples here and there. So there could be a patient who experiences da-da-da-da, and they find that during the birth experience, things are harder because da-da-da-da-da, and walk them through it without actually having to make them take the assessment, right? It's kind of that giving information, allowing them to self-diagnose or to relate to what you're saying. Or you could directly do that. For nurses that are there at the time when all this is happening, whether it's the appointments leading up to, or there, again, you could use it as an actual screener, or if you're just familiar with some of these things that you're looking for, it can help in conversation. It can help you spot some of these things that we're going to talk about. So, previous trauma, I'm going to put my glasses on here, because I wanted to read you a quote. Especially sexual trauma, and this makes so much sense, but I got to tell you, I've been a trauma therapist for years now, and I didn't think about this. Until I read it, it didn't really hit home for me. So this is a study of women who'd been through previous sexual trauma. It says the women noted that their labor sensations reminded them of their sexual abuse, and this precipitated in a reliving of the initial trauma. They felt pain, loss of control, and exposure during both events. Other links were made as well. Some women reported that the intravenous lines, the IV lines or monitoring equipment, made them feel tied down as they had been during a rape. Commands given by attendants such as open your legs, cooperate, and be a good girl were similar to those used by the perpetrator of a sexual assault. In a birth account given by a woman who'd been sexually abused as a child, one woman found that the enormous pressure of the baby's head in the vagina felt similar to the sensation of the adult penis in her vagina when she was a young child. Okay? How many of you would have any clue that this particular client was experiencing any of this? It's not going to show up on a monitor. Maybe an increased heart rate, but if she's dissociating, you're not going to see that, right? And if she's re-experiencing this kind of stuff, you can bet that she's dissociating. So if we don't have an idea of history, and if we're not checking in, and we're going to talk about grounding activities, we're going to talk about checking to see if the patient is present at different spaces along, because seeing if she is dissociating is probably the only way you're going to recognize that this mom is re-experiencing former trauma, okay? Re-experiencing former trauma means that this is going to be a trauma for her as well. You know, lactation talked about it. Somebody else over here with NICU talked about it very much affects the ability to bond with the baby. And bonding with the baby is huge in the health. And maybe dad is doing okay and he's going to make sure that baby has all that special bonding. Maybe not, because if mom's not okay, there's a good chance that dad's not necessarily okay either, because he's trying to figure out what's happening with mom. And there's a new baby in the house and everything's just turned upside down, right? So sexual trauma, and I apologize because I know some of that was really graphic, but if you are not familiar with what sexual abuse can look like or what that experience is like, who would have thought, had anyone ever thought that putting leads to an EKG or putting an IV line in could be what triggers someone's trauma? I would not have even thought about how similar that would be. And yet, you'll notice in case study 2, I think I left it in there. I'm trying to remember, I almost said her name. I'm trying to remember if this gal has a history of rape. She didn't put it in her story, but it's very intriguing to me that she very specifically said, I was tied down to the bed by the wires and I couldn't move. I didn't have the freedom to move. I felt trapped, right? Previous psychological diagnosis, especially anxiety, which makes sense, right? Because with anxiety, you spend so much energy on the workup of the what if that by the time you get to the birth, there's just a lot of negative cognitions. We think of negative cognitions with depression, and that's true, but anxiety is the queen of negative cognitions. The anxiety is the queen of the what if and the ambiguous, right? Anxiety feeds on ambiguity. The more ambiguity there is, the happier anxiety is, right? So if we're dealing with a new mom and we know that she's got a diagnosis of anxiety, one of the things we want to do for her is we want to bring everything to specifics, as specific as we can get it, because anxiety feeds on generalities. And we always want to CYA, right? And so we want to speak in generalities as much as possible, because what if we're wrong? We need to find something that we can nail down to be specific. Some kind of markers, some kinds of things to look for that's going to allow this patient to feel some level of control. Okay? First pregnancy. What was the first pregnancy like? What was their delivery like? That's a significant pre-existing thing we want to look at. Complications during the current pregnancy. That's going to feed into anxiety and fear. And what does anxiety do to the body? Who can tell me, what does anxiety do to the body? It's oh so helpful. Tension. Tension. Yes. How many medical procedures work better when you're tense? Right? None of them. So complications in pregnancy increase anxiety, not necessarily an anxiety disorder, honest to goodness anxiety, like these are real things that are happening in my body and that could happen. Those are some pre-existing. Can anybody think of other, maybe think through some people you know who had traumatic births? What are some other pre-existing red flags that you noticed? Anybody?
I think sometimes all the horror stories that their friends or relatives tell them before.
Mm-hmm.
You know, most people never tell them the good stuff. They always tell them all the bad stuff.
Okay.
And they come and say, with epidurals, some people, absolutely not. Well, why? Well, because I'm going to be paralyzed.
Mm-hmm.
Why did they tell you that? You know,
Right.
It's always the bad stuff they know or they hear.
Mm-hmm.
Or they
And I'm actually going to adjust that just a little bit, because that's one side of the spectrum. The other side of the spectrum is, oh, it's going to be fine. Everything's going to run smoothly. No problem. Second case study, you'll notice somebody had told her, if you just have enough faith, if you're just trusting God through the birth experience, you'll make it. You know, oh, once you get dilated to this place, it's smooth and free-flowing. So we've got both sides, right? We've got the horror stories, and we've got the people that are trying to tell them how their pregnancy is, how their delivery is going to go. And the expectations that it's going to be a smooth delivery, well, maybe it will be. It's your first baby. There's a whole lot you don't know, so maybe you don't want to go in there thinking that everything's going to be perfect because you just don't know what your body's going to do and what the baby's going to do. So having somewhere in the middle, some realistic expectations without all the horror stories and without this fantasy buildup of, you know, it's going to be great. Do this. If you do this formula, if you sit in this position, there will be no trouble, right? Well, okay. You had a hand up.
Along the same lines, but in that same birth plans can sometimes be a problem. It cause a lot of tension when things don't go the way that.
Right. Right, because what is that birth plan? Right? It's fighting anxiety. It gives me control. I know exactly what's going to happen. So what can we do if the birth plan has to change? What's probably the most effective thing we can do, or one of the most effective things we can do? Communicate.
It's hard when it's the 4-page single-space birth plan.
Right, you may not know what it is. And I would say if you don't have time to read the birth plan, over-communicate anyway. I don't know if you can over-communicate when a person is feeling vulnerable and scared. You can communicate wrong things. You can communicate all the negative things that could happen. But as far as letting someone know step by step, this is what I'm doing, this is, right? I don't know if any of you are familiar with play therapy, but in play therapy, the key is to track with the child. You feel like an idiot doing play therapy. I'm just going to be honest with you here. You sit there, oh, I see you're moving the blue truck over by the mountain you built. Oh, I see you chose the puppet that looks like a lion. Oh, I see that you walked across the room to that. You're literally just giving verbiage to what the child is doing, because trauma takes away language. So you may feel like an idiot, but if you suspect that you have a client that may be starting to dissociate or going through some trauma, track what's happening in the room. I see that you're rubbing your IV. I notice that you've had your eyes closed for a while. Are you feeling tired? I notice that you're grinding your teeth, or I notice that you and your husband are holding hands. It may feel really silly, but you're giving verbiage. And if they have hit a trauma spot, that part of their brain has shut down. And you giving vocabulary, not only does it help me feel safer because now I don't know what's happening because my single-spaced 12-page birth plan went out the window. But so I'm a little anxious anyway, but now if I've started to dissociate because of that, I'm addressing both just by verbal tracking. Now, those of you on the floor, do you ever just have one thing on your mind when you're working a delivery? No. Do you ever just have one patient when you're working a delivery? Sometimes. Depends on the delivery, right? So, I mean, we run into some problems, and that's where kind of administratively, and that's where some of our leaders can kind of look at, how do we do that? How do we provide that kind of vocabulary? Do we have certain things that we look for? Because it's hard to walk into one room and try and be fully present in this room and do all of these things, and then walk into another room and be equally as fully present and start. So what are the simplest things that you can track, right? And the simplest things that you can track are things that you can see. If I'm just going to say what I see that you've taken your blanket off, right? And we think, well, that's stupid. I'm going to sound stupid. I see that you've taken your blanket off. Except you're using verbalized words. Now, if you've got a mom who's talking and laughing and whatever, then probably you don't need to do tracking for that mom, right? But when you start noticing some silence, when you start noticing some of these things, verbal tracking, as awkward as it feels, is an excellent, excellent trauma tool. Okay? Any other thoughts or questions on this arena?
I was going to say a lot of support system.
Yes.
I've done therapy with moms who maybe didn't have previous trauma, didn't have any anxiety, were feeling good about the pregnancy, but then going in, it hits them that they're there alone, and that can increase that likelihood of the birth experience being traumatic for them.
Yes. Good point. Yeah.
For those people that maybe aren't used to that tracking conversation, can you give a little feedback on that? What's your experience? How do they receive those questions? And does it feel awkward?
So part of why it feels awkward is because they're not questions. They're statements, and they're obvious. They're like, you're like, this is annoyingly obvious. If someone is not in a traumatic or dissociative state, or if they're not needing that for reassurance, they might kind of chuckle at me. Like, I don't have a blanket on, Okay, if you're laughing with me, you are most likely, some part of you at least is present, okay? So if they're able to kind of joke, or if they're able to roll their eyes at me, right, then I can kind of laugh and be like, well, it's been a long night, or whatever. I can play that off a little bit. But it's very much just stating what you see. If you, let's say the birth plan has gone off and maybe they've said something like, I don't know what's happening, or this isn't the way things were supposed to be. Oh, right. What did you expect to happen right now? There I can ask the question. What did you expect to happen? If she can verbalize what she expected to happen, then I don't necessarily need to go to tracking. Instead, I can just go to explaining an affirmation. Okay, well, this is actually what we did. This is what we're doing right now. This is why we all ran in, dumped you on your head, gave you a shot of something, right? It's helpful to know why that happens. Okay, this is why the doctor is giving you an episiotomy right now, because the doctor is not likely to stop in the middle of it, but this person in their birth plan didn't want one, the doctor is giving one. If you as a nurse notice that there's some shock, or if they say, I didn't, right, you can maybe let them know. Sometimes this is something that doctors do. I'm sure that he'll talk to you or she'll talk to you afterwards if you have questions, but everything is fine and I'm here for you, just kind of that extra reassurance that I may not be able to tell you everything that's happening, but I am on your side and I'm on your team, and I will be your voice for you if you need me to be your voice, right? Okay, any other thoughts or questions? Is that helpful at all? Okay, any other thoughts, comments, questions?
Further research of if they're more likely to develop that with induction
like their body's already not like doing what it's supposed to on its own?
We'll go through in here some of the peri-birth things that are happening. Anything that can cause them to feel out of control can be. None of this, see, the thing is, a lot of these research papers that are out are based on the same few studies. It's just really starting to amp up in the research world. So, and the study samples tend to be relatively small for scientific communities anyway. So, no, I don't know of any studies that specifically address that. Some of the studies are even, and we'll get to that here in a few minutes, but are even contradictory. A lot of pain in birth is supposed to be, the early studies said pain in birth is one of the indicators that you may have post-traumatic stress disorder from birth. And then, lo and behold, another study comes and they said, actually, the significance factors of pain, they weren't significant. There wasn't a significant difference. So there's still, it's so early in some of the research that some of that's still being debated. But good question. Any others? All right. So intrapartum, and let me see here how close I am to the break, because I want to make sure we get our breaks on time. Okay, I'm going to run through some of this fairly quickly. Feel free to ask me questions about it, and then we'll come back and review after the break, because I know sometimes, especially some of you who may be internal processors, being put on the spot all at once to ask your questions is a little frustrating because you're still processing what you want to say. So intrapartum, high level of medical intervention. So that's where you talked about if they're, the word just flew out of my mind, speeding up the process. Thank you, inducing. Inducing, switching to a C-section, anything else that may happen medically. Yeah, one of the case study one talks about she found out she had staph partway through, and so they didn't really explain anything to her. They just came in and started sticking IVs, and she didn't know if it was her, if it was the baby. She didn't know what was going on. Dissociative experiences, which we're going to talk a little bit more about because that's a huge one. Lack of perceived support. Somebody over here said that a few minutes ago. Concern for life, for self or the baby is a pretty, that can have an effect. Along with that, concern for life of self or the baby is feeling like you are just a machine designed to bring the baby into the world. Everything gets really mechanical, and you don't so much matter. It's just, you're just a delivery mechanism, and doctors or nurses are just worried about getting the baby out safely, regardless of what that does to you, okay? Again, it's a perception thing. How many people in the medical field honestly don't care about the mom? That's not a reality. You would not be in this field if you did not care about the mothers. I would hope, I would assume. You wouldn't be here, right? So it's not necessarily truth, but it's perception, okay? And then negative cognition surrounding the birth events. So there was and there's an example in here because that's kind of wordy psychobabble. Okay, so I'll read you another quote here. Mother's post-traumatic stress was associated with criticisms of the partner during childbirth. This was one of the indicators. How much she criticized her partner during childbirth was an actual indicator of whether or not she'd have PTSD. Any clues from what we've talked about today of why that might be an indicator? If she's highly critical of her partner, there's probably some relationship difficulties, and people with complex trauma tend to have high levels of relational dysfunction. So it's not a guarantee, but there's a signal there that you maybe, it's one of many flags that you can look at. And then postnatal depression was associated with absence of partner empathy on either side, mom not having partner empathy or dad, and any positive comments regarding the partner's support. So we think of negative cognitions or negative thoughts, and we think about the birth experience, but indicators for postpartum PTSD, I have so much trouble saying that, can be negative cognitions, not just surrounding the birth itself, but perceived support around the birth. So if my self-talk is, these nurses just don't care, this doctor didn't come until the last minute, or my husband is doing everything wrong. If those are my thoughts that are cycling, I am at higher risk for PTSD. Honest to goodness, this side of the room, I honestly don't know if there's anything in the world you can do about it. I mean, you might be able to. If you're really good interpersonally, you may be able to kind of shift the mood in the room. Sorry about that video. This side of the room, and some of you guys who work with beforehand can help with that. The counseling community centers, your thought stopping, your cognitive behavioral therapy. Look for points of light during the birth, during the birthing process. Instead of being upset about all the things that are going wrong, find your favorite nurse. Find your favorite tech. Who's your favorite visitor? What's the favorite thing that was brought to you? What's your favorite style of ice chip? I don't know if they have options on whether they get crushed or chips or whatever. But, I mean, what can I find that I can choose my favorite out of or the point of lights out of? And if I go into the experience prepping that, you know what? This is going to be really hard on your partner if your partner's there, if you're not alone. This is going to be really hard on your partner as well. So we're going to practice. Even now, we're going to practice having grace for our partner leading up to the birth. So when you're super angry with him, I want you to just kind of find a way that you can just have grace for him, and maybe you try it like once a day, right? Any of those kind of CBT style mind-changing exercises are going to happen. In the middle of it, I don't know if there's a whole lot you guys can do to change cognitions when they're already in pain and have a million things going on, okay? So dissociation has a lot of hallmarks, but two of them that can be relatively easy to spot and diagnose if you're talking to someone is derealization, right? This is when I don't quite feel like the room around me is in focus. Things feel maybe kind of foggy or not quite real, right? Distorted, not real. So this is derealization. The reality around me doesn't quite feel like reality, okay? It's not psychosis. They know what's there. It just doesn't feel real, okay? And then we have depersonalization. This is kind of that out-of-body feeling. I almost feel like I'm watching myself doing something. And it doesn't have to be like, oh, they're actually out of their body. It just feels like it. It feels like they're not completely in control of their body. Auto-writing, this is a higher level dissociative thing, but people will journal and they'll be like, oh, I don't really remember writing that. Okay, well, that's because part of yourself that you've shoved down to hide has decided to visit you while you're journaling and in a quiet meditative place. And then when you get busy again, right, state-dependent learning, you don't even have to have DID, state-dependent learning, something that I do in this frame of mind, I completely forget about when I'm in this frame of mind, right? So auto-writing can kind of fall into that. Again, out-of-body experience is kind of what that feels like. Any questions on dissociation, depersonalization, derealization? Are you guys familiar with those things? Do they sound foreign? Do they sound weird and not real? No?
I think part of that, you think about, but you don't put the meaning to it.
Mm-hmm.
You know, there's little segments of each one that you kind of go, oh yeah.
Mm-hmm. Yeah, kind of that zoned out feeling. That's how we refer to it. Because we all do healthy dissociation. Road hypnosis, some of you have been dissociating for like the last hour. There's healthy dissociation. It is a normal inbred defense mechanism that sometimes gets out of control. And birth can be one of those times when they might feel this. And it might feel a little bit scary. So if you've got a complex trauma survivor, dissociation's old hat. Dissociation isn't going to be scary for them because they've been dissociating since they were like 3. They know what this feels like. They know what's going on, right? Somebody who's never had a dissociative experience before and has their first one while giving birth, that definitely increases the risk of PTSD. And it may be because you guys may or may not know it, but you are professionals. There's a power differential. And while there are some people who will do their best to make you not feel like a professional and act like you know nothing, there are other people who will do everything you say, and even if they completely disagree with it, they will not speak up, right? And those people are at a higher risk, okay? All right, I went 5 minutes later than I wanted, but we'll go ahead and take our break. Think about any questions that you have. We'll start off the next session with questions, but stretch, walk around. Let me know if you need anything. All right, I promised you that I would start with questions and comments about the things that we've just gone through. So I'm going to open the floor. Yeah, did you want to start? Yeah.
Well, yeah, I just agree with
somebody else had said about the terminology. I guess as a labor and delivery nurse, I recognize some of that behavior. I just don't know the terminology. And I think as a labor and delivery nurse, at least for me, it's my responsibility to stay focused and keep in mind that it is their experience, not my job. And how much power I have when I even walk into that room.
Yeah.
And sometimes, we discussed at the break, sometimes that's really hard to do when you are burnt out. You're just like, oh my gosh, it's another thing. I try and enter the room every time I go in like, hi, my name's Mary, don't get freaked out about the hair. I was like, hey, I'm here to blah, 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 and how do you see this going? So trying to and stay focused, and that it's their experience and not mine. I'm just there to help facilitate that.
Yeah, and I love that casual language. I'd given this feedback to you directly, but that casual language of, hey, how do you see this going? Normalizing is a beautiful thing. And the more clinical I am, shall we go over your birth plan? It almost feels like there could be a wrong answer. I might have the wrong answer. Whereas more of that casual, like the body language and the casual, hey, how do you see this going? Is this meeting your expectation? Like you would talk to a friend, can be really helpful in preventing that traumatic space because it helps remove the power differential. It's exactly why you want to be super clinical in some instances, because you want that power differential there. But sometimes you want to take down that power differential a bit, and being really casual with your language is a great way to do that. Any other thoughts, questions, conversations that came up during the break?
Sometimes, too, you have to look at the whole room. It's not just the mom.
Yes.
You look at, the significant other. You might have the obsessed grandma, a crazy and a sister that has read a couple things. So you got to kind of see who's the alpha in the room.
Yes.
And the mom might not be that person or might be that person.
Yes, which is huge in giving them a voice, right? Yes, and if I'm going to give mom a voice, somebody might have to escort the louder voice out for a minute so that I can actually hear mom's voice, because the other voices in the room might be louder.
Sometimes, too, it's like you want to come in and be that strong mother voice to nip the room.
Yes.
Maybe by the middle of the shift you can do it and get by with it. You can't do it right in the first 5 minutes because then they'll hate you. So you have to kind of feel things out. Some things you can get away with and not piss the whole room off.
Yeah, so there's this kind of balancing act.
Yeah, you still need to be in control of your room. Because if you lose control, you're sunk.
Right. I imagine. Because it is a medical procedure. There are medical things that need to happen. And you need to be able to be heard when you need to be heard. Right. Today we're doing a lot of talk about the mom being heard, but there can be some pretty scary things if you are not heard as well. So finding that balance, that's good. Thank you. Any other thoughts or comments as you guys have? My guess is half of you were making lunch plans over the break. But I wanted to just make sure that I give some space for that. All right. So this is just a review before. We've talked about this. Just a reminder that there is a need to look at common themes and resiliency factors, right? So common themes, these are perceptions, right? This comes from a study where they took comments from the women who had been diagnosed with postpartum PTSD, and these are the 4 things that were the most common things that were said. But you have to remember, it doesn't mean that they all had lack of care. This is perceived. Perceived lack of care, perceived lack of communication. Actually have the follow-up sentences for each of these. So to care for me, right? Perceived lack of care. Was that too much to ask? Feeling like, and this is where you get your moms who feel like, I was just the vehicle to birth the baby. For whatever reason, they started to believe that. There may have been a medical emergency and the mom didn't even realize that you were trying to save her too. Or the baby's life could have actually been in danger at some point, and you needed to just do what needed to be done. And that was perceived by the mom of, you didn't notice my pain. Like, what I experienced during that moment didn't matter, right? So that's where we sometimes we have to do that wraparound care of going back and explaining after the fact. So just because we didn't have time to normalize something or explain something or track with something in the moment, in the emergency moment, there's no reason that maybe a little bit later when the emergency has passed, we can't go in and normalize it. And that's when we can give the verbiage. The verbiage does not have to be there in the midst of the emergency. You guys are medical, especially this side of the room, you guys are medical personnel. You're not going to sacrifice actual health of a person so that you can explain, so that they can understand. There are times when there just is not time for that. But that's where the wraparound care can come. That's where passing off to a different shift and maybe letting the nurse on the next shift know, hey, if you get a chance, this is what happened in this room. Would you mind going in and just kind of normalizing that for this mom, letting her know that this sometimes happens, it's okay, and why those things happen, right? Lack of communication. Again, you almost can't over-communicate data, right? We can over-communicate opinions, but data, it's very difficult to over-communicate data. What did they put after that? Why was this neglected? Why was communication neglected is the question. And then, interesting, feeling powerless. The way that they worded it here was to provide safe care. So yeah, safe care. So these comments they perceived as not getting safe care. And the women said, you betrayed my trust. I felt powerless. And then that the end justifies the means. And that's kind of only the baby's life matters. The end justifies the means. So I thought that was really, you betrayed my trust, right? This idea of betrayal, because I think people, maybe not with OB doctors, because they see them and they kind of build a relationship, but with nurses and the personnel that are in the room at the time, around the time of giving birth, there's kind of an automatic trust for a lot of women that you have their back, that you're going to protect them, that you're going to cover them. And when that communication is missing, or when they perceive that care is missing, it actually feels like betrayal. It's not just anger or disappointment, it's actually betrayal. So think of how you perceive betrayal. It feels different than just anger, right? I'm annoyed by someone. I'm annoyed by my phone company because they lie to me every time I turn around, right? I'm annoyed by that, but I did not have a relationship with anyone in my phone company, so I don't actually feel betrayed. I didn't, and so I just have some anger there, some anger issues with my phone company. But I don't have betrayal. Betrayal feels personal. And betrayal, because it feels personal, is going to be a red flag or a danger sticker for PTSD. Especially when we look at some of the more complex symptoms of PTSD. Okay. So, any questions about these common themes? No? You guys are so good. All right. Resiliency factors, developmental history. I don't know how much access you guys have to developmental history. I don't know what that process is. This side of the room actually probably has more access to developmental history, maybe some of you guys, than the nurses. I don't know how much you guys actually go over that part of their chart. Is that something that you guys look at when you're looking at labor and delivery charts?
Can you explain what you mean by
developmental history? So this family of origin, did they walk, talk on time? Did they, right? These are things, this is childhood information. Childhood information. Absolutely none of that, right? So you're walking blind into this resiliency factor. You guys are more likely to have gathered this kind of information on your clients. I don't know if you do in the pre-birth class, but it's not a horrible idea to facilitate some conversation about family communication patterns, perceptions of being a parent, perceptions of being a child. Some of those things are going to come out just in conversations in the parenting classes. So you guys can kind of bring some of that to the surface a little bit, and you might see some red flags based on what the conversations are. Belief system. So it doesn't matter what belief system you have, but research shows that if you have some sort of a belief system, usually it's connected to some kind of faith system, and especially if you have a faith community, that is a resiliency factor, okay? Because there is support in community. Any kind of community is going to be a resiliency factor, but a belief system tends to, not always, but if I'm going to generalize in a huge way, you're more likely to have thought about existential issues if you have a belief system of some sort, right? If I've been avoiding existential issues like the meaning of life and all of that kind of stuff, I'm actually at more risk of trauma than if I have explored those questions within myself. Because being able to make meaning is one of the resiliency skills. So again, it doesn't matter what faith background or what belief background they're coming from, but if they have one and if they've struggled through some existential questions, they're going to be more resilient than someone who has not, okay? And again, unless it comes up in casual conversation, unless the nursing staff is just really good at like, hey, who do you go to when you're feeling really bummed or whatever, kind of the support system questions it might come out in. I'm not sure. You guys you might, if you look to see if they've requested a chaplain, that might be a clue in that question. But it doesn't necessarily. Some people have not looked at any of those questions and don't really have a belief system, but because there's a chance that something might happen in a hospital, they'll request a chaplain. So, it's not necessarily an indicator that they have that as a strength. Prior experiences, we talked about that, right? If the prior experiences are positive and healthy, I'm going to be more resilient. Or if I have successfully navigated previous trauma. So previous trauma doesn't mean that I'm sunk forever. If I've successfully navigated previous trauma, my ability or likeliness to bounce back is actually higher, okay? Preparation for expected stress. Again, this is debatable in birth trauma because they need to have realistic expectations. If their expectations are not met, that actually becomes a risk factor instead of a resiliency factor. But education about what are some things that are possibly going to happen. We talked a little bit over the break of it's not just that you dilate to 10 and boom, there's a baby. There are other things that the body actually has to do that a lot of women have no clue that the body actually has to do all of these things. And so there's not that expectation. That's why you guys have this birthing class, right? So the more that they can kind of expect, my body's going to go through these stages. And it's going to look different than the other people in my class. But I know that these are some of the benchmarks I can look for. Again, anxiety, ambiguity, I give you benchmarks. Now I have something specific to sit on. So I feel like chaos. I don't know what's happening. I don't know what's happening. This word is said in labor delivery, and all of a sudden it connects to a word that I had there. Okay, I'm back on the train. Now I can relax again. I heard something familiar. That's one of my marker points. That's one of my stakes in the ground. Okay, I have some idea of where I'm going from here. And then there may be chaos that ensues for a little while again, and then boom, there's another one of my markers. So actually, you guys, I don't know how much you guys communicate with the pre-birth classes and the nurses on the floor, but that would be really helpful to know that there are some key words that nurses on the floor can use that tie into what they've learned in the pre-birthing classes as just those anchor points. This is a place where I feel like I can have control because I recognize that word, and now I have some idea of where I am in the process again. Okay. Successful flight or fight response, that's psychobabble. Having a voice, feeling like I have some control. If there's any place that you can give a choice, give a choice. It might be, would you like me to put the IV in now, or would you like to take a nice deep breath first? That's a choice, right? You're still putting the IV in. You have already made that decision. But they get a choice. They can either take a deep breath first, or they can let you just put the IV in directly. That's a choice. So anywhere that you can give someone a choice, you are going to empower them, and that is giving them a voice, someplace that they have control. encourage them to use their internal resources. Actually believe in these moms. You know what, I can tell that you're hurting right now, but I so believe that you have it in you to get through this. I believe in you. I trust you. I trust you as a mom, and this is going to be okay, right? After birth, if you start to see some things, you know, the wide eyes or they seem a little disoriented, you know what? I believe in you. I believe in you. You've got this. Lactation, you're going to be able to do this. You've got this in you, sweetie. We may have to adjust some things, and it may be that breastfeeding's not going to work for you, but you've got the mom genes in you. It's going to be okay, right? Internal resources, we want to do everything we can to encourage. So then, of course, in counseling, you guys are all about internal resources, I'm sure. That's half the job of counseling is helping people see what their internal resources are. And again, in the classes, looking at how can I identify my strengths before I go into birth, right? What are some things about me that are going to put me on the right track? Because it's really easy, especially when hormones are going everywhere, to think of all of the reasons why I'm going to be a horrible mother. And you'll notice in the first case study, I think I left her words in there. She says, I failed at birth. I failed at giving birth, right? And so can we store up some of those positive cognitions? Even if things go wrong, it does not correlate to you failing at giving birth, right? External support. If you have volunteers, train your volunteers in how to talk to a mom in labor. I don't know if they allow volunteers in labor and delivery or not, but hospital staff and volunteers, I don't know if you have clerks that sit out in the hospital. I have had some fabulous hospital clerks when I've gone and done visitations on different wards, and I've had horrible hospital clerks. Like, they're grouchy, and I'm bothering them because they need to be doing something else. I spent a year going to hospitals and doing mental health evaluations in different wards, and there were some wards that you just felt really welcome in, and there were other wards that you're like, just do your thing, get out of our way. I'm like, oh, I hope that the families that come here don't feel this way. So, but just kind of understanding hospital staff and volunteers, what can they do? Are they kind of equipped in normalizing, in how to have conversation, and how to kind of joke with people or talk with people, how to, you know, bring them down, how do I talk someone down? Maybe even training some of them in grounding exercises, which we're going to learn here in a few minutes. Yeah. Any questions on resiliency factors? Any that you want to add? Anything you guys who are clinical have so much rich experience that I don't have. So please feel free to step in and share stories or examples, because that is going to help everyone in the room, maybe more than what I'm saying, because they're going to actually get to hear from you guys from medical. Any thoughts on, I know some of you guys are clinical too, but I'm kind of focusing over here. Any thoughts on resiliency factors or things that you've seen or experienced? Yeah.
This is tiny, but I think that internal resource of being able to tell a woman that she can do it, putting your hand, you know, it's okay, touch her.
Yep.
Hand on a knee and say, hey, you've got this. I see you're starting to get scared. Take a deep breath and relax.
Yes.
You can do it. It's only a few more minutes. You know, they don't know. They look at the clock and they're like, I can't do this for 10 more hours.
Mm-hmm.
We're right now. Let's do this next interaction.
Yeah.
And giving her the power to feel like she can do it is
Yes.
huge. And verbalizing it.
Yes. Yes, and I love that you're concentrating on the here and now. You're not telling her you can get through 10 hours of labor, but we can do this. And we can do this moment together. Perfect. Thank you for sharing. Anybody else have some stuff to share in that area of resiliency? And all right, we'll keep going. Okay. Bessel van der Kolk, because I do so much somatic work and body work, I do a lot of reading and listening to him. If it's true that the core of our traumatized and neglected patients' disorganization, which is a great word for what we see when someone's dealing with trauma, things just are kind of disorganized in the mind. So at the core of this disorganization is the problem that they cannot analyze what's going on when they re-experience the physical sensations of past trauma. So we talked about the specifics of sexual trauma, but can you guys think of, and any of you, clinical or non-clinical, what are some things that might cause someone to re-experience physical trauma of the past? Non-sexual physical trauma. Yeah.
I've had, and obviously we see them before, not when they're actually in the hospital, but I've had several people verbalize to me they're just walking into a hospital, whether they watched a grandparent die or whether they had, a dad had a heart attack or whatever it might be. It's physically walking in, and they talk about getting an IV or a catheter, and they have those anxiety symptoms just sitting in our classroom, just talking about it. So,
Yes.
And I don't know what it look after they go through it and go into the hospital. I have no idea how it actually turns out, but it's amazing how just talking about that can really make them relive it.
Environment is huge. So I've had a client before, it was actually the husband, had medical trauma and some craziness that I won't go into, especially because it's being videoed, but had some medical trauma, and walking into a hospital was a major trigger for him, the sights, the smells, whatever. Now, thankfully, they went in through the ER one day, and he triggered all over the place, but when it came time to actual birthing, there was something about the birthing room that he said the smells weren't as antiseptic. It didn't smell as much like a hospital, and he didn't actually trigger. So that one was the husband, but 100% it could be the wife who's had some kind of physical trauma and maybe had to visit the hospital for that, or a trauma that they were in the hospital for, and those sights and smells, don't have to do anything. All they have to do is walk in. Can you think of anything else that might cause some sort of flashback for physical types of trauma?
Any type of serious accident or injury where you experience that physical pain can bring back.
Yeah, the sensations of pain. What if you've had someone who's been in a very traumatic, life-threatening car accident, and they have back labor, right? That could totally trigger re-experiencing of some of the things that happened when they had that near-death experience. Yeah, there was somebody over here.
I just have a blood pressure test. I tend to just leave it on there and it goes off, but I have a patient that could not have like something holding her there squeezing.
Okay, yeah.
Feels like somebody's like squeezing.
Squeezing her arm, probably having some somatic flashbacks every time that goes off. And because she didn't get the warning, when the nurse comes in and puts the blood pressure cuff on, she's mentally prepared, I'm going to have my blood pressure taken, but especially if she's been drifting off to sleep or anything like that, and suddenly she feels that pressure on her arm, 100% could send into a flashback, yeah.
A woman in recovery with IV drug use and having to go through all of that.
Yes.
I'm worried about being triggered.
Yes, yeah. And I could see there'd be the triggers of the IV drug use and also maybe even some fear of pain medications. And what will that do to my sobriety? And, yeah.
Even sometimes you'll get the occasional patient that can't tolerate a certain little dashboard scan.
Right.
Like, it's something that you need to do to figure out where they are in their labor, but, when you go to check them, you blow and it affects the lips go like this.
Yes.
To the top of the bed.
Mm-hmm.
You have to talk around the wall.
Yes.
Then you have to wonder, okay, and there has been a patient like you wonder, like you talk to the doctor, does she have any history of like sexual abuse or, trauma that way? Something that you have no knowledge of, or maybe you've never told anybody about it, but it's something in your mind that you have to think about, like, I just can't talk around the cliff. It's a barrier to care.
Yes.
You don't want them to feel like you're assaulting them every time you need to figure out what's going on in her labor process.
Yes. Especially if it's someone that has not yet processed that trauma. Maybe they don't actually remember it, but the body does. The body remembers a lot that the mind has decided just we're not going to deal with. And so she may or may not know that she has a history of sexual abuse. All she knows is that it's very painful. And there's a feeling of there's no control. I love that you kind of explain things, you slow down, talking through it. This is where I'm going to put my fingers. You may notice this. Here's your word. If you need me to stop, this is your word. Maybe it's stop, maybe it's whatever. But just kind of anything that can give them some power to know that's going to happen. And okay, we're going to count to we're going to take a nice deep breath and count to 3. And when we release that, I'm going to count to 10, and by the time I'm done counting to 10, we're going to take a break. And I'll let you know if I need to recheck, or maybe you need to count to 25. I don't know how long it takes to do the check. I've not had a kid, but that gives them something they can control. Okay, right now, while I'm doing this, this is what I'm going to be doing. I want you to count with me back down from 10. 10, 9, because counting backwards requires more brain power than counting forwards, and so it might help. But yeah, I would imagine that's fairly common. And not all of my clients who've had sexual trauma have even told their OBs that they have. Mm-hmm. Yeah.
Something that's, I mean, you don't think about, and we're talking about the wires and the cords.
Mm-hmm.
And if you talk to the patients and say, okay, say our monitors are always on the right side.
Mm-hmm.
So what if you have an IV here, you don't want to put the blood pressure cuff, so that's over here and that's crossing over them.
Mm-hmm.
So you can always ask them or say, does it bother you if that's across? Because one of my coworkers, and I give her a lot of grief, but she gives it right back. That was one of her things. She had surgery, and she absolutely, if that one blood pressure cord is across her, and all of her patients, she makes sure it's always around.
Kind of behind.
It cannot be across because that is one of her pet peeves. You know, and sometimes I don't think about that. But it is something as small as one cord across, it's not even tight, can make them feel like they're held down or claustrophobic.
And on the other side of that is if I give her a voice about that, she may not actually trigger. So whereas she might trigger because there's a cord across her, if I actually bring it to the cognitive brain and say, hey, this cord's going to come across here, is that okay for you? Now all of a sudden she has power and is less likely to experience trauma from a cord draping across her. So yeah, that goes back to how many places can I find to give the mom a voice where it's okay to give her a voice? You know, good, thank you. So yeah, so we want to, did I finish this quote? No, okay. So cannot analyze what's going on when they re-experience physical sensations of past trauma, but that these sensations just produce intense emotions without being able to modulate them, right? That's what happens in a trigger. I don't necessarily have rational thoughts, but my body and my emotions are doing things that I don't understand. I can't coordinate them, right? Do you guys know that whole model of the brain thing? So let's say this is your amygdala, this is your reptilian brain, this is what controls your fight or flight symptoms. The hippocampus just covers it so nicely, and the hippocampus is what develops, was it around age 2 or something that it kind of covers? And this is what helps us be kind of rational social people that can navigate different situations. And then comes up to this, I can never say that word right, this part of the brain, the front area. So what happens when we have a trauma trigger of some sort, or if we feel like our life is in danger, again, perceived. It may not actually be in danger, but I perceive that it's in danger. What happens? Boom, hippocampus flies offline. For 20 to 30 minutes, I will not be able to think rationally. Right? So if I have someone that triggers in my office, I know that we're going to ease back into talking about anything that requires logical thought. I'm not going to try logic. I am not going to try data. It's going to be purely emotional responses. I'm going to go with breathing. I'm going to go with grounding. I'm going to go with eye contact. I'm going to go with minimal physical touch that just brings that person present. This is where you are. This is what we're doing, right? Because it takes, I say 20 to 30, maybe 15 to 30, depending on how intense that was. But it takes a while for the brain to come back online from front to back. So, and cover that amygdala again so that we're not just having fight or flight responses. Sorry, that was just an extra brain lesson that you guys probably already know because you're in the medical field. But we want them, our people, we're helping people stay in their bodies and understand these body sensations. That's where the tracking comes in and all that, which I've already talked about. So I'll keep going. All right, core experiences, Judith Herman, core experiences of anyone who is a survivor of trauma is at some point they felt disempowered and a disconnection from others. Those are just common things to look for in language. I feel disconnected, feel like I have no power. Probably they're not going to say those exact words, but things that make you think of those. We're looking at a risk for PTSD. So within the helping relationship, this is something I train counselors and social workers in, and so I adjusted it a little bit for nurses, but I still think you guys are in a helping relationship, you know, the different aspects of it, but a helping relationship. So these are some things we can do. Developing rapport. You don't have to take an hour to develop rapport. If you're honestly welcoming someone, if you can, I kind of call it carrying home with you. If you just look at everybody like they're in your inner circle, they're going to feel that, right? And so I can spend 5 minutes in a room. Hey, how's it going? You know, whatever I need to do as a nurse. And you know what? I'm going to check on you again. I'm doing some rounds. It's probably going to be about 30 minutes before I'm back here, but this is the button you can push if I need you. All of a sudden, I have created a wonderful rapport because I actually gave this mom an expectation of when I will be back, right? Now, that might mean if there's an emergency when I'm running past her room, I'm going to run by, stick my head in and say, hey, something's going on. It's probably going to be another 10 minutes before I'm here. Boom, that took me 10 seconds to say, right? But I'm giving that expectation that I'm coming back. I have not abandoned you. I'm here with you on this journey. And if you can't get a hold of me, you can press your button and someone will respond, even if it's not me. But I myself will come back and check on you at some point, right? Developing rapport. Empathy, repetition. You guys know this stuff. It's what you do. You see it day in and day out. This is normal for you, but it's not normal for the mom. Most of them being in that position. I don't care if the mom's a labor and delivery nurse. She's not been on this side before if it's her first child. And so remembering that there's so much going on that you can't see, and there's so much going on with perceptions that we have no clue of. And so developing that rapport and just having that empathy that it's okay, and I'm going to walk through this with you. I'm not going to judge you. It's so easy to judge. Am I the only one? I am the worst judger in the world, I think. I'm like, well, that's just too whatever. And I had to catch myself and be like, Jeannie, hello, do we need to list all your faults, right? I can get so judgy in certain areas, and I really have to calm myself on that. You guys may not have that problem. I do. Hypochondria concerns, right? So what do you guys know? What are some thoughts, facts, or otherwise about hypochondria? Anybody know what hypochondria stems from? Well, let's start with this. Let's start with the negative. What are your gut responses when someone talks about a patient that's hypochondriac? Or a friend that's a hypochondriac?
Something's wrong somewhere, or they wouldn't be having these symptoms. You know what I mean? Something.
So you actually do believe that there's something wrong somewhere?
Yeah. I mean, you just go, hey, something's out of whack somewhere.
Okay.
I mean,
Yeah. Yeah.
Ask them how they're doing.
Yeah.
It's going to be an hour conversation of every system they've got.
Yeah. All of a sudden, I don't want to. I'm going to skip these intake questions because they're going to say yes to every single one. That's right. This was supposed to take 10 minutes. I've got a whole bunch of other people to do it. Uh-huh.
You're like, holy smokes. And
Yeah.
before I just kind of think, I mean, I have nurses that have patients like that, and I'm just like, oh, that poor nurse, because
Yeah.
they keep talking them off the cliff. Oh, this is normal. You have to keep saying, oh, this is normal. Oh, this is normal. This is
Yes.
normal. It's okay. Over and over, but it's exhausting.
Yes. It is. It is. Yes.
A lot of that, but I think it's because it's establishing a control thing. The moms need to be able to control something, and the kid can't control it themselves, and they can control them and touch their baby or whatever, any questions that they ask the doctors and nurses.
Mm-hmm. Yeah.
They will experience trauma because not everybody has been able to make you
Yes.
as a control, which it can be exhausting, but I think that's just an old part of our job is re-answering questions
Mhm.
over and over. Just to
Yeah.
make sure that it's resolved.
Yeah. So to recap, for those in the video, there can be frustration with hypochondriacs, with people who notice every physical thing that's going on. It can make our jobs harder. It can take longer. We feel empathetic for other people that do. Sometimes, especially in the NICU, it's a plea for some kind of control. I want to understand or control something, right? And so those are some of the answers that have come out. Often with hypochondriac, there often is some sort of trauma that is behind that, whether it's a medical trauma. At some state that I've worked in the past, I've worked in 4, so that helps cover things a little bit. In some state that I've worked in the past, I had someone who, I've actually had a couple clients, GI problems. I don't know if it's just the nature of them and because they're so closely tied with anxiety, but I've had a couple clients where those GI problems were never normalized or explained. They were just dismissed. And this particular person had some GI problems. Well, when I dug a little further into her history, found out that she had actually had a cold, went to the doctor, and in less than 12 hours was on breathing machines. That pneumonia hit her so fast and so hard, and so she's, ever since then, would definitely fall into the hypo. She notices everything that happens in her body because it took her off guard and it took her by surprise. And I find that my patients that are more of a hypochondriac, almost all of my patients that are trauma survivors, especially complex trauma survivors, have some level of hypochondria because they notice. They're hypervigilant. They're noticing everything that happens in their body, unless they're dissociating, in which case they're choosing not to feel pain and not to do whatever. But they're noticing it all. So the normal things that happen in our body that because we're not hypervigilant, we don't notice it, they notice. Or they give value, like with medical trauma, previous medical trauma, oh no, if I don't tell someone about this pain, they're going to miss something and I'm going to be on a ventilator in 12 hours, right? And so kind of that idea of the empathy behind hypochondria and how do I, and then we just have our over-informers. We actually have, I'm an over-informer. You do not want me as a patient. I'm an over-informer because I am a good student. And if you ask me what's happening, I'm going to tell you every sensation. Oh, so in this, well, yes, I had that 3 weeks. Oh, and then, I don't think I'm dying. I don't think I'm sick. I'm not a hypochondriac, but I answer, right? And so for me, my doctors and nurses need to kind of prep me and say, okay, I'm just looking for things that have happened in the last 2 weeks, or I'm looking for things that on a scale of 1 to 10 were probably higher than a 4. Okay, now I don't have to over-inform you, right? Now I know what you're looking for, and I'm still a good student if I tell you just the things that are over a 4, right? So you've got overachievers like me who I know I've annoyed a nurse or two in my day, and I'm like, oh, and what about this? And because I'm curious, I am terribly curious. I don't want to Google. I want to ask someone who knows. Hey, so what if da-da-da-da-da-da-da? They're like, you're fine. You're not dying. Oh, I know I'm fine. But what if da-da-da-da-da, right? I am a nightmare patient. So, yeah, just be glad that I'm not living in Elkhorn now. If I ever have to walk into one of your offices, you're going to be like, she already warned us. Yeah, so hypochondria returns. We want to have that empathy and maybe look at some things that we can do that's going to help that person not feel like they have to inform us of everything. Okay. Unconditional positive regard, Carl Rogers, for those of you that are therapists, he's the king of unconditional positive regard. Regardless of how stupid I feel you are acting right now or how completely irrational you are, I am going to choose to believe that there is something inside you that is good and worth drawing out. Right? And I'm going to search for that part of you and pull that part forward if I can. I'm going to be authentic. That word. Authentic. I'm going to be authentic. I'm going to be genuine with who I am because if I want this person to stay present, I need to have a present that they can be present with. And if we have our own trauma triggers, it can be real easy for us to disconnect. Right? I feel disrespected. I've just disconnected. Okay, there are certain clients that come in that I have to work so hard because they hit just those right buttons, and I will start to disconnect because it triggers on my own history or my own past. And so I start to disconnect, and I have to be very purposeful, internal talk to say, Jeannie, you just left the room. Get back in here. The client's by themselves, right? Because emotionally I have left the room. I need to re-enter the room and then deal with my own stuff, my own self-care, my own whatever I'm station there. Right? So I have one client, she's a trauma survivor. And she will feel her blankets and notice the texture of her blankets. And that grounds her. She knows the texture of her blanket. It reminds her that she's in her current bed. She's not in a bed from any place she's been in the past. She's in her current bed. So even hospital blankets have kind of a distinct texture, right? So even touching the hospital blanket, what do you notice? What do you notice when you touch that hospital blanket? If someone's dissociated enough for you to use that type of grounding tool, they're not going to think you're stupid. Okay? They're not going to care. They're going to, can you touch the blanket for me? What do you notice? You could even get really creative and be like, can you feel the top of your blanket for me? Is it feeling kind of warm or is it cold? Right? And maybe you're checking on the temperature of their blanket, which you don't actually care about, but it gets them touching the blanket with an open hand. So using your hands I have people who use essential oils, right? So a strong smell that's comforting. I don't know if people ever do that in the birthing rooms or not, have some of their essential oils there. I don't even know if they're allowed. But yeah, so sense of smell, sense of taste. If it's going to be taste, you want it super sweet, bitter, or sour, okay? Because we're trying to ground to this moment. And that, did you guys know that little trick for little kids when they ruminate? When a little 2-year-old says the same thing over and over and over and over and over again, sticks something sharp tasting in their mouth, a neurological thing jumps in the brain and it pulls them off the track of that little circle that's been picking up speed in their brain. So, yeah. I can't promise that they won't begin doing it again in 5 minutes, but for the moment, it allows that kind of jump. I have a reawakening activity that I'll do with my clients after I feel like they've dissociated. So I'll let you guys do that with me here. And you've been sitting for a while, so hopefully this won't hurt too bad. I have them rub their hands together harder and faster until they start to feel a little bit of heat go up the nerves. And once they finally feel that heat going up the nerves, they clap. Okay? Some of you are like, I still don't feel heat. And that it's a fun little thing. And I'm surprised at how many of my clients are like, oh, that actually feels really good. Because, right, I'm working against the dissociation. I'm waking up those nerves. I'm bringing them back into the present. Sometimes it's as simple as looking them in the eye and saying, hey, I'm so-and-so. My name is. And I'll do this sometimes with clients I've had for like a year. This is Jeannie. We're in my office on Farnham. And, we've been talking about da-da-da-da, but we're here in my office. Hopefully you guys won't have someone dissociate to that level, but there's something about talking to someone while you have their eye contact that feels like partnering, okay? You don't need to drill into their soul. I'm reading everything you're thinking. Right? But there's something about that eye contact that creates some partnership. Also, mirror neurons. Does anybody know about mirror neurons? Seriously? The counselors don't know about? No. Okay, she's nodding. You guys know about mirror neurons, right? Okay. Mirror neurons are awesome, right? Mirror neurons are when I behave a certain way. So I had a couple in one of the states I worked in, not Nebraska, and like they would not ever be watching this video. But anyway, he was very aggressive, and he would get all up in his seat, and his wife's cowering and crying in the corner, and eventually I did not see them as a couple, but those first few times while I was still trying to figure out what was going on, and so I would have to get really big in my body language, and then my body language would slowly get quieter. And sure enough, you watch the videos, and his body language would get quieter, and he'd ease back in because of mirror neurons. Mirror neurons mean that what I do, you're likely to do. So if you're hyperventilating, and you guys probably do this all the time and don't know it's because of mirror neurons, okay. Yeah, I wonder if you can just breathe with me. Oh, well, not only are we breathing with them as a guide, but we're breathing with them because the mirror neurons start to mirror our body language, right? Kids on a playground doing something, you shout, stop, right? You yell one word at children, one word. Ah! You meet their energy with that one word, stop, no. And then you bring your body language back down, And as you're calming down and getting on their level and your voice is dropping and da-da-da-da, you'll start to notice that the child is not in crisis at the way that they will. This happens. For some people, this is really difficult, and I really appreciate you pushing through that. You know, just that normalizing, casual kind of thing. Protect confidentiality. You guys have had more than enough training on confidentiality, so I'm not going to beat that horse. And communicate clearly. I've talked about communication a lot. You hear me say communicate, communicate, communicate. You cannot over-communicate data. You cannot over-communicate partnership. We want to communicate. All right. Safety from self and symptoms. Hopefully you guys know this formula already, being in the medical field. Number one thing you do when you start to see symptoms is you do a basic medical check. Is everything medically okay, right? Next, we want to restore biological rhythms. So what can I do to help this mom and her family eat? How can I help her with maybe eating healthy things? How can I help her with patterns of sleep? Even in the hospital, is there anything that we can do as a staff that's going to help get some sort of rhythm back in this mom's life? Because the biological rhythms are a resiliency factor, and they're going to help them recover better if there's anything we can do for that. And hormone stuff throws off biological rhythms, of course, like crazy, right? And then you want to do reduction of intrusive symptoms. I'm going to look at my notes because I feel like I wrote something down last night on that. I have to put my glasses on. All right. Grounding, breathing, body work, and refer out for therapy. So, grounding. Anybody familiar with grounding practices? One of our therapists over here. A couple of you are. All right. Basically, grounding is getting at least 1 foot of the client into the here and now. And it can happen using any of the 5 senses. The more senses that are engaged, the more effective the grounding may become. Some people ground pretty easily, so it doesn't matter. So grounding, I did this with some GI nurses, and I got some feedback from one of them on a form that said, you're talking about trauma, and yet you told us we had to do something. So I'm going to recommend that you try some of these things with me, but you do not have to do anything that I tell you to do. But for those who are game, I would like for you to look up here, and can you tell me about my earrings? What can you tell me about my earrings? Shiny? Okay, what else do you notice about my earrings? They're square. Mm-hmm. Yeah. Yep. I have 1 in each ear. There are 2 of them. Right? Basic stuff, right? I could say instead, what do you notice about this glass of water?
You can decide either it's half empty or half full.
Okay, and I actually would move you away from that, and I'd say I don't want you to judge the glass of water. I want you just to describe.
What you see.
I want you just to tell me what you see. What do you notice?
You have a bent straw to drink out of.
There's a bent straw to drink out of. Mm-hmm. It's plastic. It's clear. It has water in it, right? That's probably what I would have redirected their answer to. Yes, it has water in it. Has a lid on it. The straw's white. Mm-hmm. So this is a great grounding exercise for anxiety, because what did I say? Anxiety feeds on ambiguity and big stuff. If I can focus you into something small and get your focus there, it forces focus in, which signals to the body all kinds of stuff that lets the anxiety fall, right? So those are some through my eyes. That was through eyes. If we're all kind of just quiet in this room, what do you hear? Ventilation system, air. Mm-hmm. Buzzing of the lights, especially up over here. Mm-hmm. Yeah. Say that again.
The rustling of people.
Yeah, people's movement and rustling, right? So if I'm in my office, I might have someone, hey, what do you notice? What are some sounds that you notice? Go ahead, if you will, put your hands flat on the table and tell me what you notice. What do you feel when you put your hands on the table? Cold, some of you said? Slick. Mm-hmm. Yeah. Okay. Somebody's table's sticky. Oh, they're not sticky. Okay. So she was surprised by the lack of sensation there. Right? So I have one client, she's a trauma survivor, and she will feel her blankets and notice the texture of her blankets. And that grounds her. She knows the texture of her blanket. It reminds her that she's in her current bed. She's not in a bed from any place she's been in the past. She's in her current bed. So even hospital blankets have kind of a distinct texture, right? So even touching the hospital blanket, what do you notice? What do you notice when you touch that hospital blanket? If someone's dissociated enough for you to use that type of grounding tool, they're not going to think you're stupid. Okay? They're not going to care. They're going to, can you touch the blanket for me? What do you notice? You could even get really creative and be like, can you feel the top of your blanket for me? Is it feeling kind of warm or is it cold? Right? And maybe you're checking on the temperature of their blanket, which you don't actually care about, but it gets them touching the blanket with an open hand. So using your hands I have people who use essential oils, right? So a strong smell that's comforting. I don't know if people ever do that in the birthing rooms or not, have some of their essential oils there. I don't even know if they're allowed. But yeah, so sense of smell, sense of taste. If it's going to be taste, you want it super sweet, bitter, or sour, okay? Because we're trying to ground to this moment. And that, did you guys know that little trick for little kids when they ruminate? When the little 2-year-old says the same thing over and over and over and over and over again, sticks something sharp tasting in their mouth, a neurological thing jumps in the brain and it pulls them off the track of that little circle that's been picking up speed in their brain. So, yeah. I can't promise that they won't begin doing it again in 5 minutes, but for the moment, it allows that kind of jump. I have a reawakening activity that I'll do with my clients after I feel like they've dissociated. So I'll let you guys do that with me here. And you've been sitting for a while, so hopefully this won't hurt too bad. I have them rub their hands together harder and faster until they start to feel a little bit of heat go up the nerves. And once they finally feel that heat going up the nerves, they clap. Okay? Some of you are like, I still don't feel heat. And that just, it's a fun little thing. And I'm surprised at how many of my clients are like, oh, that actually feels really good. Because, right, I'm working against the dissociation. I'm waking up those nerves. I'm bringing them back into the present. Sometimes it's as simple as looking them in the eye and saying, hey, just, I'm so-and-so. My name is. And I'll do this sometimes with clients I've had for like a year. This is Jeannie. We're in my office on Farnham. And, we've been talking about da-da-da-da, but we're here in my office. Hopefully you guys won't have someone dissociate to that level, but there's something about talking to someone while you have their eye contact that feels like partnering, okay? You don't need to drill into their soul. I'm reading everything you're thinking. Right? But there's something about that eye contact that creates some partnership. Also, mirror neurons. Does anybody know about mirror neurons? Seriously? The counselors don't know about? No. Okay, she's nodding. You guys know about mirror neurons, right? Okay. Mirror neurons are awesome, right? Mirror neurons are when I behave a certain way. So I had a couple in one of the states I worked in, not Nebraska, and like they would not ever be watching this video. But anyway, he was very aggressive, and he would get all up in his seat, and his wife's cowering and crying in the corner, and eventually, I did not see them as a couple, but those first few times while I was still trying to figure out what was going on, and so I would have to get really big in my body language, and then my body language would slowly get quieter. And sure enough, you watch the videos, and his body language would get quieter, and he'd ease back in because of mirror neurons. Mirror neurons mean that what I do, you're likely to do. So if you're hyperventilating, and you guys probably do this all the time and don't know it's because of mirror neurons, okay. Yeah, I wonder if you can just breathe with me. Oh, well, not only are we breathing with them as a guide, but we're breathing with them because the mirror neurons start to mirror our body language, right? kids on a playground doing something, you shout, stop, right? You yell one word at children, one word. Ah, you meet their energy with that one word, stop, no. And then you bring your body language back down, and as you're calming down and getting on their level and your voice is dropping and da-da-da-da, you'll start to notice that the child is not in crisis at the way that they were when you yelled stop. Right? So I'm going to meet someone at their energy level, and then I'm going to choose to slowly bring them down to the energy level where I feel like it's safe for them to be. Mirror neurons, they're awesome. Okay? All right. Sorry. I need to get moving because we are past our break time. If you have questions about these, you can ask me later. But this is just a list of safety things that you may or may not have time to do. One word about relaxation versus hard exercise. Large muscle movement is amazing. It's such large muscle movement, whether it's singing, deep breathing is large muscle movement. Anything you can do that's large muscle movement is going to be super helpful. So if we can help these ladies leave knowing what is okay to do to move large muscle groups and what's safe, what can I do? Maybe I'm not going to start running right away, but maybe I'm going to start singing in the shower, or I'm going to do some deep breathing, or I'm going to do some stretching, right? What are some things I can do to get those large muscle groups moving? Because what I found is when there's trauma or high stress, even high anxiety, if I go straight to relaxation, it doesn't always work. I have to do something physical first to move the body, to get those muscles moving, that anxious energy going, right? And then I can go to the relaxation exercise, okay? And one of the most fun breathing exercises I do, did you guys know that like something about the vagal nerve, and I'm not medical, so I'm going to get some of this wrong. If you breathe out longer than you breathe in, sorry, I'm getting dry. My body is telling me to shut up. If I breathe out longer than I breathe in, it automatically triggers the dorsal whatever stuff in my body that signals the not the sympathetic nervous system, the P, there you go, nervous system, to actually start calming myself down. Well, we do something every day that is breathing out more than breathing in. A sigh. Beautiful, simple thing. Can you just sigh for me? And our body, even just now, because I've been kind of tense up here, I totally feel the little tingles going down my legs, sighing. I'm like, oh, there we go. I'm starting to get relaxed. So, okay. And references, that means break. You guys have the PowerPoints. We talked about the scales. Go, fly, be free, run, dance.